So, welcome everyone. And my name is Adelina Comas-Herrera. I'm the director of the Global Observatory of Long-Term Care. And together with my colleague Naz Zalehi, we're delighted to welcome you to today's webinar of the Global Observatory of Long-Term Care and the Quasi-Experimental Methods Group. So I'm going to very quickly introduce the Global Observatory of Long-Term Care. Some of you may know about it, but maybe it's new for some of you. The Global Observatory of Long-Term Care is a platform for cross-national learning to improve and strengthen care systems, and it's part of the International Long-Term Care Policy Networks. And what we're trying to do is to identify shared challenges, showcase how different countries are responding to them or different localities, share research evidence, and facilitate collaborations. And the way that you can take part in the observatory is basically by sharing your knowledge. So you can share with us publications you have written, you can contribute to long-term care profiles, methods and topics guides. And the really interesting way of taking part is by being a member or organizing an interest group. Interest groups organize webinars, also share relevant publications. And we're gradually building up a list with all the resources that you are all sharing. I'd like to share with you the list of webinars that we have for the rest of the year. We have next week, we've got two, one on unmet need inequalities and care poverty, and one on home-based care provision from the South, with examples from South Africa and Brazil. On the 5th of November, we have one on qualitative methods and process tracing. The 7th of November, we have one on older persons, disabilities, and social protection in African contexts. We've got one on evidence pain management on the 11th of November. 12th of November, we've got one in Spanish on care in the community. On the 24th of November, we have a webinar from the Innovations Interest Group. The 28th of November, we have a full-day event full of presentations and discussions on changing the narrative on long-term care to celebrate the International Day of Care and Support. And finally, on the 10th of December, we've got one on whether AI can understand meaning, and that's exploring large language models in qualitative research. So as you can see, we've got a very interesting list of webinars, and my colleague Naz will be sharing links so you can join the ones you'd like to. I'd also like to mention that we have a new interest group on long-term care in China. We kind of set it up last week in Beijing in collaboration with Peking University. And you can join this interest group if you have a particular interest in long-term care in China. And to do that, first of all, though, you have to become a member of the Global Observatory of Long-Term Care, and then you can choose which interest groups you'd like. So you can choose the one that is hosting today's webinar on Quasi-Experimental Methods, others that we have by now about 20-something, and of course this one on China. So with that, I'd like to finish here and hand over to my colleague Javiera Cartagena-Farias, who's leading the Quasi-Experimental Methods Interest Group.
Thank you, Adelina. So as Adelina said, I'm the lead of the Quasi-Experimental Method Interest Group. And just to give you a brief overview about this group, so basically we would like to bring together academic policymakers and practitioners that have an interest in knowing how we could better evaluate causal effects on long-term care policies and intervention. So this is a very methodological group, and where we believe that we have the potential to shed light on what works in long-term care. And also we believe that method matters and that they can have a real impact. So our main aim is to provide a platform for knowledge exchange and generating new methodological ideas. And I know I said it's strongly methodological, but everyone is welcome. And as Adelina said, there are many resources on the website that make that easier for everyone. Just to tell you about some numbers, we are at the moment 93 members. After this meeting, maybe we will be more. There's expertise for more than 41 countries or regions. At the moment, the majority of us are researchers, so academics, but there are also some people from the policy sphere and also from advocacy organizations. If you are not part of the interest group yet, but you want to be part, well, first you need to join and create a profile for the Global Observatory, and then you just can complete a small form with your name and your details, and you can join the group. And Adelina mentioned also that there are many resources like topic guides or that we publish the publication. So please get in touch with me. My email is at the bottom of the slide, and I will be happy to publish any publication that you have. And also, if you want to write a topic guide, I'm happy to discuss with you what method could be suitable. And now we have a presentation from Wenjiang Zhu. He's at the University of Peking in China, and he's going to present the effect of China's integrated medical and social care policy on functional dependency and care deficit in older adults. And my understanding is a difference in difference approach. Over to you.
The first part is introduction. China has the largest older population in the world, and the aging process is accelerating. According to United Nations estimates, the number of people aged 65 and above will reach 390 million by 2050. The number of older adults with disabilities or potential disabilities is increasing significantly, and the combined demand for healthcare and long-term care among older adults is becoming increasingly prominent. Our team previously estimated in the Latin Public Health that the number of disabled older adults in China will increase from 45.3 million in 2020 to 59.3 million in 2030, and a death of 14 million. The growing nuclear resistance and declining fertility of families have made traditional family-based care models unsustainable, highlighting the urgent need to develop new care models. How can we respond to the challenges of elderly care in a scientific and effective way? According to PK University and Licensed Commission and the National Structure from China's government, achieving healthy aging is the key. Maintaining the health of older adults is an investment in both human and social capital. It aligns with the United Nations Sustainable Development Goals and upholds the global right of every individual to attain the highest possible standard of physical and mental well-being. Providing long-term care for older adults with disabilities helps ensure that they live a life of dignity consistent with their fundamental rights and freedoms. Promoting the integration of healthcare and elderly care services is essential for meeting the diverse and multi-level needs of the population. It represents a key structure to optimize the provision of health and care services for older adults and an important pathway for actively addressing population aging. China's integrated medical and social care policy is one allied with of the United Nations Decade of Health Aging 2021 to 2030 and closely corresponds with the World Health Organization's integrated care for older people framework. The two-part is feature of the IMSCP. The first phase is concept proposal and practical exploration. The second phase is policing preparation and system development. The third phase is pilot exploration and rapid development. The fourth phase is experiments, promise, and pathway optimization. Here are five main models of the IMSCP. The first one is senior care facilities set up their own internal medical facilities to enable on-site medical practice. The second is medical institutions established that all post-acute care or LTC facilities. The third is healthcare providers partner with senior care facilities. The fourth is hospitals and health centers dispatch healthcare practitioners to deliver medical service. The five is professionally operated integrated medical and senior care institutions run by social force. Here are the goals of the IMSCP. The core pathway is building a comprehensive, continuous, and multi-tiered service system. The core role is aimed at addressing the fragmentation between healthcare and social care service. Here are 10 key tasks for the IMSCP. The first one is enhance collaboration between medical and senior care facilities. The second is expanding medical services within senior care facilities. Here we can see the total 10 tasks. China's IMSCP aligns with the WHO integrated care for older people. Both aim to optimize support for older persons by integrating health and social care services with the goal of maximizing everyone's intrinsic capacity and functional ability to promote health aging. This integrated care model delivers people-centered and well-coordinated care services. In addition to addressing diseases, it also focuses on intrinsic capacity and functional ability, providing continuous integrated care along the trajectory of traits in intrinsic capacity and functional ability is essential for meeting the diverse needs of older persons. For the MCP, healthcare service include geriatrics rehabilitation and nutrition, focusing on meeting vaccine rather than just treating diseases. This helps seniors avoid repeat hospital visits, prevents health decline, and allows them to live at home longer. Social care services provide professional nursing and daily assistance to reduce family burden and improve senior quality of life. This model makes continuous comprehensive care more accessible to seniors and their families. At a broader level, it also helps distribute medical resources more efficiently, lowers healthcare costs, and increases trust in the healthcare system. The third part is evaluation. This study utilized the data from the 2014, 2018, and 2021 waves of the Chinese longitudinal health longevity survey. The study sample comprised individuals aged 65 and above. This is a flow chart of the sample section. In the analysis for functional dependency, the sample size is 380. In the analysis for car deficiency, the sample size is 1,144. Outcome variables include functional dependence and car deficiency. Functional dependency was measured based on the interval of need. Low dependency is needing help less than daily. Medium dependency needing help at regular times daily. High dependency required 24 hours care, and independence means free from care. Care deficiency means by subjective care confidence and objective care deficiency. Subjective care deficiency is measured by the question: do you think the help that you received could meet your needs? If older adults answered partly met or unmet, we think we think he is we think he has a a subjective care deficit. The objective deficiency means by the question who is the primary caregiver when you need assistance. If the answer is nobody, we think he has a, objective care deficit. The independent variable is IMCP, is the interaction of treat variable and post variable. This table is the parent cities of the IMSCP in 20 and 40 years. This is a map of cities when where the intervention and cultural group areas are located in this study. The cultural variables include age, sex, education, marital status, numbers of chronic diseases, having old age insurance, having medical insurance, living arrangement and area of residence. In sensitivity analysis, we further include indoor non-clean energy use, indoor musty smell, frequency of eating fresh fruit, frequency of eating vegetables, frequency of eating meat, smoking status, drinking status, physical exercise status, access to adequate medical service, and total family income. We further include some macro level variables at the city level. This table is the characteristics of study participants. In 2021, three economics awarded the Nobel Prize in Economic Science. Their most significant contribution lies in promoting the use of natural experiment methods in economics for causal inference, thereby advancing the methodology of causal research. In this study, the IMSCP in 2016 provides this chance. We use the difference in difference DRD models to investigate the associations between China's IMCP and functional dependency in older adults and care deficits in those who need care. I denotes participant index, C denotes city index, P denotes province index, T denotes index of the CLHS survey and is equal to 0 if the participant is in the 2040 wave. Sensitivity analysis was conducted using the PSMDRD and SDRD. This figure is the percentage points increase in different dependence states across interest and cultural groups from 2040 to 2018. With strength that IMCP mainly reduce low and medium dependency. This figure is the proportions of older adults with functional dependence or care deficits. Both the prevalence of functional dependence and the proportion of care deficits were higher in parent areas in non-parent areas in 2040, but lower in parent areas by 2080, indicating a positive correlation between the IMSCP and the reduction of both functional dependence and care deficits. This figure is the transition frequency and percentage between different outcomes across two groups. Here is the main results of this study. Using panel data from 2040 and 2080, the study finds that the IMSCP is significantly associated with reduced functional dependency and fewer care deficits among older adults. We also conducted placebo tests. The curves plotted points representing placebo estimates are mostly distributed around 1 and lie far from the vertical density line, indicating the actual estimate that passing the placebo test. This figure is subgroup analysis. We also use 2040 to 2021 waves of the CLSS to investigate the long-term effects. The results revealed a weakened long-term effect of the IMSCP or functional dependency, though it persisted for males, while its effect on care deficits strengthened. We further incorporated 3 mobility-related items into the measurement of functional dependency, namely visiting neighbors, walking 1 kilometer continuously, and using public transportation. The results remained robust and consistent with the main findings. We also used the SDRD method to test if the results is still significant. This is the PSMDRD model. We also conducted a balancing test, common sport test. They all passed this test. This is the main result of PSMDRD method. The fourth part is conclusion. The IMSCP associated with the mitigation in functional dependency among older adults in the short term, with this effect primarily observed in individuals with low to medium dependency. The long-term association reveals that the effect of reducing functional dependency exhibited a general weakening trend, which may be attributable to age related physiological decline. For older adults with functional dependency, the IMCP was significantly likely to reduce the care deficits in the short term, with the association growing progressively stronger. Here is a possible interpretation. The accessibility of healthcare services is closely linked to the health status of older adults. Similarly, the availability of social care services is associated with care deficits, guided by the principles of aging in place and integrated care. The means of integrated care facilities is to provide health management and long-term care services for older adults. This model reduces the time costs with frequent transitions between home medical institutions and care facilities, thereby enhancing the utilization of health assessment, intervention, and management services. The achievements of the IMSCP have profound implications for both healthcare and social care policies. These results demonstrate that an integrated service delivery system can effectively meet the complex and diverse needs of the aging population. Policymakers should consider scaling up and refining the integrated care policy to address the growing care demands of China's aging demographic, promote healthy aging and enhance the quality of life for older adults. Traditional interventions targeting individual older adults have limited impact. In contrast, policy-driven approaches that improve systems and environments and can benefit a broader population. These measures effectively delay functional dependence and reduce care deficits without relying heavily on trades to individual or family-centered lifestyle. Here are some suggestions. Effective resource integration should be achieved by encouraging resource sharing between healthcare and senior care institutions through partnerships. Delivering home-based and community-based integrated care services bridge the facility and service gaps in rural and underdeveloped areas, promoting coordination among healthcare, insurance, civil affairs, public health, and finance departments is a key step in integrating fragmented service. This is dissemination of this article. This article is a cover article published in the Lancet Health Longevity, and this article was reported by the Health News in China. That's all. Thank you for watching.
Thank you, Wenjiang. Derek, do you want to lead the discussion? Or if you have a question, maybe yourself, I don't know. Or if anyone else have a question.
Derek, you're muted.
Thank you, Javiera. I'm happy to take questions now from anyone in the audience. We have just over around 50 minutes, just over 10 minutes for questions. Please raise your hand if you have any questions, or if you prefer to put them in the chat. We do have some questions there already, I think, so I'll try and keep track of those as well. Javier. Javiera, do you want to go ahead?
Yes, I mean, my question is quite general. It's just about because you use a difference in difference approach, whether you could tell us a bit more of how the areas are selected where this integration policy is taking place, and how they were chosen. Yeah, if you could tell us a bit more about the policy itself, where it's located, and how the kind of the rollout process. Yeah.
Okay. Okay. Um, the IMSCP has 5 models of integrating medical and social care services. Uh, one of one of the models is providing providing integrated care service for home-based and community-based older adults. This question referred to the home and community-based elderly care service parents. I'm not I'm I haven't seen this article, but I don't know which data used in this article. Maybe it's Charles. In Charles in Charles questionnaires, it refer it reference some questions about home and community-based questions, but they but it is not the parent policy at the city level. It may be individual level. This is my guess. My guess. In my opinion, the HCBS may be one of the 5 models of the MSCP. That's my answer. Thank you.
Thank you. And then we also had the question from Javiera was asking more about your difference in difference approach. Is that correct, Javiera?
Just
Yes.
all the places were chosen, what local areas were available, or what they had the intervention and which one they didn't.
Yes, we conducted some group analysis.
I saw a map. You had a map somewhere. That one. Oh, it was. I think it was the map that you have above and can see the areas. No, you pass it. I think it was 27. Yes. So my question: how the intervention group is selected?
The intervention group select based on the other previous work slanted and selected by the Chinese government. Pilot cities were chosen based on their existing foundation for integration work, which included the actual developed status of medical facilities and senior care facilities, as well as their willingness to participate in experimental initiatives. Subsequently, they were recommended by their respective provincial authorities. This is a process of selecting the pilot cities.
Thank you. And then there was a related question with regards to the potential for the program in rural areas. And is there any, you mentioned some subgroup analysis. I don't know if that was included in your subgroup analysis.
Uh, From this figure, we can see in panel A, the effect in urban area is not significant, but in rural area, its effect is significant. Maybe in rural, the foundation of integrated care is poor than in urban areas. But according to the principle of declined marginal effect, so the effect in rural areas is higher than in urban areas. That's my explanation.
Thank you. That's very interesting. Just checking the chat again. With regards to the subgroups, and I think also how you describe the potential for the program to be rolled out, you mentioned that the program has some savings in terms of cost because of less movement of patients between health and social care facilities. Have you looked at any of the costs associated with developing and implementing the program, as it were? So in terms of additional provision of staffing or anything like that?
Okay, that's a very interesting question. In this article, we ignore this, but we will investigate its effect or in our next plan. Thank you.
Thank you. Thank you. That's interesting. Are there any other questions? Oh, there's a comment in the chat. Could the marginal gains in rural areas occur from a lower baseline level of service access in rural areas? That is, there is unmet need, and by providing services, the initial gains are large. I think you had one of your graphs had a suggestion that the baseline for the intervention group was actually poorer than the baseline for the control group. But I suppose this is also relating that to the urban versus rural question.
In our okay, that's a very interesting question. Actually, we tested this difference between rural areas and urban areas in baseline, and we found that the we found that the proportion of the proportion living in rural areas and in the intervention group is were lower than in urban areas. And it's a common sense in rural areas. The status of integrated care is poor in urban areas due to their socio-economic status. Thank you.
Thank you. That's very interesting. Are there any other final quick questions, or shall I hand back to Javiera, I think, to wrap up? I don't see any further questions, Javiera, if you want to maybe mention any forthcoming seminars or anything like that.
Thank you. Thank you, everyone. And thank you for the questions and Wen-Yang for the presentation. I think Adelina mentioned the next webinars at the beginning. So I don't know, Adelina, if you want to say anything.
No, from me, just to say thank you very much for today, and we will hear from the group when you have the next webinar over, and we will write to everyone. Remember that if you'd like to find out about our next webinars, do register on the Global Observatory website so you can find out what we're doing. So thank you very much. Thanks for an excellent presentation, and thanks for the colleagues who stepped in to help us with the technical issues. Have a wonderful rest of your day or evening. Thank you. Bye.
Thank you.
Thank you. Bye.